us. And without further ado, patient-centered care with Jake Stein, MD, MPH, Oncologic Emergencies, and this is March 13th, 2024. Dr. Stein, welcome. Good to see you.
Good to see you again.
Very glad to have you here. Let's find out a little bit about you for our audience. We've got that. We're not going to read all of that, but if anyone wants to go back and watch the recording, they can. MD, MPH, medical oncologist caring for patients with sarcoma, a group of rare and heterogeneous cancers. You have a particular interest in caring for young people with cancer and how to improve their care and outcomes. Cancer care delivery researcher, you study how to improve how we get people the cancer care they need. And medical educator, he works with residents and fellows and enjoys helping teach folks how to think about complex medical topics. And finally, number one, proud father of two, 4-year-old and 1-year-old, a musician and a basketball player in his free time.
So things are busy at home, as you can guess.
I'll bet. And what kind of music do you enjoy playing?
Classic rock, folk rock, basically anything.
Great. Well, we're really glad to have you here today. I mentioned poll everywhere. This is our first question. It's always a softball. In this case, an oncologic emergency is an acute health problem caused by the cancer or its treatment and requires immediate treatment. So you can let us know in just a moment if you think that's true or false. These are all anonymous, so we encourage people to take their best guess on all of these. While we're waiting for folks to start doing that, we've got our ACCME disclosure, our ANCC disclosure, and there's our poll everywhere. So we'll wait a few seconds, give some folks an opportunity to answer that.
It looks like we have a sharp audience here. They're right on top of it.
I think so. We've got 100% there. So without further ado, Oncologic Emergencies, I'll turn the controls over to you.
Thanks, Tim. Yeah, thanks for giving me the opportunity to speak today. I gave this talk a couple of years ago, and it sounds like that has been a well-received talk, and I'm really thrilled to be back here giving it again. So, so let's just dive right in. By the end of this talk, I'd like for anybody who's watching to feel like you can identify the most common oncologic emergencies, describe some key elements to diagnosis, and recognize some of the critical aspects of management of those oncologic emergencies. The first one, I'll just go ahead and read the case for us, and there'll be a multiple choice at the end. So as you're reading this, kind of think about what you would do in this situation. A 75-year-old man with a recent diagnosis of lung cancer presents to the emergency department with back pain. He mentions that he's had some falls, his feet feel clumsy, and an MRI spine is obtained and shows a vertebral body mass with extension into the epidural space with compression of the spinal cord and associated cord edema. And so the question is, what is the most appropriate next step in management? Option A is to biopsy the mass. B is to give some steroids followed by radiation therapy. C is platinum-based chemotherapy, and D is radiation alone. So I think this will now go to the poll everywhere. Please, I agree exactly with what Tim was saying earlier. Go ahead and vote. It helps from a learning standpoint to make that commitment in your mind of what you think the right answer is, so that when we show the right answer, you can either pat yourself on the back or learn something. And again, we have a very sharp audience, as we knew from the outset. So you guys got it right. The right answer here is corticosteroids followed by radiation therapy. A biopsy is probably not indicated in this case, given that we know that the patient has lung cancer. Platinum-based chemotherapy may be reasonable for his lung cancer, but we first need to address what this cord compression, and we'll talk about that more in a moment. Radiation therapy is certainly appropriate, but corticosteroids are really a key element in the management of cord compression. So sure enough, spinal cord compression. I doubt we have a bunch of radiologists on the call, and I'm not asking anyone to be able to diagnose it yourself, but you can see on the image here a pretty prominent lesion pushing back on the spinal cord. And this is a relatively common occurrence. It happens in up to 1 of 20 of all patients with cancer, and a much higher rate in those with spinal metastatic disease. And we see it frequently in some of our most common cancers, breast cancer, lung cancer, and prostate cancer. But basically anything that can go to the bone can kind of break through and put pressure on the spinal cord. So lymphoma, myeloma, renal cell. And this is independently associated with a poor prognosis. So the development of spinal cord compression has a median overall survival of 6 months. So this is often a late-stage complication of whatever cancer happens to be affecting the patient. This is an oncologic emergencies talk, so obviously it is critical to diagnose and treat as soon as possible. But the reason to emphasize that here is that the patient's neurologic status at presentation really predicts their long-term outcomes. And so if the patient has a delay to present and is already having weakness or gait instability, that is going to affect their long-term outcome. But similarly, if they come to the emergency department and we as medical providers are delayed in getting the care that they need, that could also impair their long-term neurologic outcomes. This, we'll have a couple of references, and I mostly won't make mention of them, but this one right here is really an excellent multidisciplinary review, and I think it's very readable for almost any stage of medical training. So I encourage folks who are interested in cord compression to look at this Journal of Clinical Oncology article from a couple of years back. And here's another one that's actually good across all of the emergencies that we're going to talk about today from the Cancer Journal for Clinicians. So the etiology, I mean, sort of obviously this is generally from these masses in the spine pushing back, as you saw in the image before, putting pressure on the spinal cord. They can also be from metastases that are within the bone that either cause things like compression fractures that then push bony fragments out, or displacements of those bony fragments into the spinal canal. And you can imagine how that would be particularly difficult from a surgical standpoint to manage. And in addition to direct extension, there's also a significant inflammatory burden that happens here. There's a lot of cytokines that are released, inflammation within the spinal cord and around the tumor that really drives some of the neurologic problems as well as pain. These are most common in the T-spine, and that's because there's less space to operate there. So these certainly there can be mets in the lumbosacral spine, but there's a little more room, especially around the cauda equina, where they're not necessarily going to put direct compression on the spinal cord. And then C-spine is a really critical location when it happens, but fortunately is more rare. The most common presenting symptom is back pain. And this is worth discussing for a moment. You know, there's a lot of movement in medicine towards choosing wisely and being judicious in imaging tests and not doing overdiagnosis. And that's very appropriate. That is absolutely appropriate. And so there's a push away from imaging patients that present with back pain. That is patients without red flags. And it's really important to remember that a patient with a current or recent history of cancer, that is a red flag. And so these are not the patients to be sort of judicious and say, well, we shouldn't get imaging. This is a high-risk situation, and I would say most of these patients really merit some advanced imaging to make sure that you've ruled out this critical complication. The other symptoms that we associate with cord compression, like weakness or bowel and bladder dysfunction, you can see are not universally present, so I wouldn't rely on those as diagnostic criteria, or they can be late findings. So, as noted before, you don't really want to wait for them to be having significant neurologic dysfunction in order to make the diagnosis and initiate the management plan. So I think we've made this point that early recognition is absolutely essential. MRI is really going to be your imaging modality of choice. And certainly whenever I get these calls, I recommend that folks get the cervical, thoracic, and lumbar spine, get it all in one imaging because, number one, often the sensory level that's affected doesn't quite line up. There's all this inflammation and cytokine release, and so that may mean that the patient is experiencing pain or nerve deficits that don't line up precisely with where the location is. But the other reason is that up to a third or more patients have multiple sites of disease. And so if you're going to need to treat the one site that's causing compression, you really also want to know if there's a second site, maybe just above or just below, that needs management at the same time. And the radiation oncologist can treat multiple sites of bone disease at the same time. How do we treat it? Back to the question, Steroids are absolutely critical. Dexamethasone has better CNS penetration than things like prednisone, and it improves the chances of walking after treatment. It improves pain scores, so these are really meaningful outcomes, and so absolutely necessary for spinal cord compression. The way I dose this is 10 milligrams IV as soon as you have the diagnosis, and then 16 milligrams daily in divided doses. The exact schedule doesn't matter so much, but I typically do 4 milligrams Q6 hours. Opiates are appropriate. Again, lots of push to get away from opioids for patients who don't need them. That's absolutely reasonable. This is as I mentioned before, this could be in the patient's last 6 months of life. And so this is a painful condition, a cancer-related complication. These patients should not be suffering as they deal with this. So opioids are very appropriate. And then you want to call the surgeons and the radiation docs, even in the middle of the night, to get this going. The best outcomes that we see with cord compression are with essentially tri-modality care. So they get the steroids, they get radiation, and they get surgery. The decision of whether to do all three, and particularly the question of surgery, is a more nuanced one. You can imagine that a patient with a single site of disease who otherwise is doing really well, that a big neurosurgery might be the best thing for them. But we can also imagine how an older patient with advanced disease that's progressing in multiple locations, a big surgery that then has a big downtime afterwards during which you can't give them systemic therapy might not be appropriate. So you want everybody to be involved so that you can make a multidisciplinary decision involving the patient and their family and their goals and preferences so that you can get the best treatment plan possible. All right. And again, put the questions, write down your questions or put them in poll everywhere for the end. If you have any, I'd be happy to answer them. But I'll move straight on to case 2. This is a 54-year-old man who presents with facial swelling and cough. His vitals show he's afebrile, he has a little bit of a high blood pressure, slightly tachycardic, slightly tachypnic, and his O2 sats are sort of borderline on room air. He has facial plethora, whatever that means, as well as bilateral jugular venous distension, and a CT scan of the chest reveals a left upper lobe mass with compression of the superior vena cava in addition to mediastinal lymphadenopathy. So as before, we're going to have multiple choices. What's the most appropriate next step in management? It could be that multiple of these are correct, but what should we do next? Chemotherapy, combined chemo and radiation, steroids, a mediastinoscopy and biopsy, or radiation therapy alone. And here's that poll everywhere. I love that we're getting, people are engaged and clicking and giving us some answers. All right. So we've got a range of answers, which I love. That means maybe we'll have something to teach here. I would recommend mediastinoscopy and biopsy. So a lot of folks said steroids. There are some scenarios in which steroids might be the appropriate avenue, although I would argue this question stem doesn't give us quite enough to point us in that direction. For example, a lymphoma, that could make sense. The patient will probably ultimately need option B, combined chemo and radiation therapy, but we actually don't know what kind of cancer this person has yet. And so I have given them some vital sign abnormalities, but they're not in absolute extremis. And so often in these cases, we have a little bit of time to get the diagnosis right so that we can take care of them in the best way possible, not just right now, but over the next several months or years. So this is SVC syndrome. This is caused by occlusion of the superior vena cava. And I'm sorry, I don't have a pointer, but just above the right atrium is the large sort of purple structure. Just above the right atrium is the superior vena cava, which is the largest vein above the heart. There's the inferior vena cava, which is down below the heart. And this is where all of the blood comes back to the heart, deoxygenated, to then be recirculated, reoxygenated, and pumped back out to the blood. This is a low pressure vessel, which is true of most veins. And there's all these structures, as you can see from this anatomic image, that a tumor in any one of these locations, and the lungs are just adjacent as well, could put pressure on that SVC and cause it to be occluded. And the symptoms really are from that back pressure, that venous distension. And one important thing to note is that the exact location of compression really matters. And so if it happens below the azygos vein, that's the sort of vein that loops off and goes down along the spinal cord, along the vertebrae. If it happens below that, there's no way for the pressure to be relieved. Whereas if it happens, I'm sorry, I've said that backwards. If it happens above the azygos, there's no way to relieve that pressure. There's no offlet valve. If it happens below the azygos, that extra pressure can go through the azygos vein down and filter up through the IVC. So the location does really matter for people's symptom burden. There are some non-malignant causes, particularly blood clots that might be associated with a catheter placement or a pacemaker. You can have some sort of weird infections. This is just an excuse for me to say fibrosing mediastinitis, which is a complication of histoplasmosis. But this is an oncologic emergency talk, so we're going to talk about the cancer causes. Non-small cell lung cancer is the most common etiology, and that carries a poor prognosis. Small cell lung cancer is the next most common, which is certainly a very high-risk lung cancer, but doesn't independently have worse prognosis with SVC. And non-Hodgkin's lymphoma is a better prognosis than either of those and can also be occurrence. The presentation, as I mentioned, sort of depends on where it happens and also how fast the mass develops. And so depending on the degree of collateralization, meaning are there veins that are able to distribute that pressure and sort of relieve that pressure, that can relieve the symptoms as well. And so facial, neck, and upper extremity swelling, that's what I'm talking about when I talk about plethora, and we'll show an image in a second here. Dilated chest veins, many of us have seen this in the setting of patients with cirrhosis or liver disease. They can develop what's called caput medusae, which is sort of little veins that you can see sticking out on their abdomen. We can see the same process in SVC syndrome on the chest. Shortness of breath, cough, hoarseness, that can either be from the SVC compression itself or the recurrent laryngeal nerve, which is also right there. And then the most concerning factor would be if the patient had headache, confusion, or lethargy, because those are indicators of high intracranial pressure, and that is a much more dire situation. Here you can see on the left, when the gentleman's arms are down, his face has normal color, but when he puts them up and increases that intrathoracic pressure, that increases the obstruction of the SVC, and you can see his face gets sort of red and swollen, and that's what we call facial plethora and should clue you into the idea of SVC syndrome. In this case, you're going to want a CT with contrast because you want to see actually what's happening in and around the blood vessels, and the contrast allows you to see that. If somebody had, for example, a severe contrast allergy, you could use an MRI that's a venogram, so again, specifically looking at the blood vessel. And most of the time, the answer here is to get a tissue biopsy. Mediastinoscopy is one of the quickest ways to get in there. If the radiology folks can do a CT-guided biopsy, that might be very appropriate as well. And I'll talk about reasons why you wouldn't have time, but mostly you have a little bit of time to figure this out, because if they have lymphoma, they need a rituximab-based regimen. If they have lung cancer, they need a platinum-based chemo regimen. Those are very different treatments, and you want to give the patient the right treatment. And so you usually have the time to get the information you need. The scenario where you need to do something sooner is if they're having stridor or respiratory compromise, so it's compressing the trachea as well and they can't breathe, or lethargy or coma, suggesting severely high intracranial pressure. In these cases, you have a couple of options. One is pursuit of an endovascular stent placement. So this is vascular interventional radiology, can go in there and place a stent to try to reopen that SVC. This is not as effective as we would all kind of imagine it to be. And so just because the stents are flexible, and so a big tumor that's putting pressure can actually sort of push through that stent. So that's not usually a final answer, but can temporize things if needed. And the other thing that happens in the most dire of cases is actually that you intubate these patients so that you can control their intracranial pressure, get the tissue biopsy, and get them initiated on therapy. Radiation is going to help within a couple of days. Chemo is going to help within a couple of weeks. Steroids, as many of you highlighted, can have a role, but I would say it's a more limited role. So patients who have clear evidence of laryngeal edema, so all that swelling and back pressure is causing swelling in the larynx, then steroids make sense to reduce that swelling. In something like lymphoma, it also can make sense because lymphoma will respond to steroids. But if it's a new diagnosis of lymphoma, you don't want to give the steroids before you've had the chance to get the biopsy because it may reduce your diagnostic yield. Diuretics are sometimes thrown around as a treatment option, but I would say they don't have clear benefits, so I would mostly not consider those part of the management. Again, feel free to pop your questions in the chat or in the poll everywhere for the end. We'll move on to case 3, which is an 85-year-old woman with fatigue, lethargy, and constipation. She has advanced breast cancer, she has bony metastatic disease, and was otherwise healthy other than this cancer diagnosis. And labs are notable for an elevated calcium of 15. And I'm sorry to do this to y'all. You know, when I take tests, I'm reading and I'm trying to think of the answer as I'm reading it. And so you might have been thinking, oh, fatigue, lethargy, bony, it's going to be hypercalcemia. But then I went and gave you that. So I'm sorry. So now we have to decide what to do about it. And again, next step, most immediate next step. Multiple of these may be correct, but what are you going to do first? A bisphosphonate, Lasix, steroids, or fluids? And here's our poll everywhere. Got the answers rolling in. Sort of a smattering across answers. And you all have highlighted the 2 most important elements of care, although we're having a late surge for what I think is the first most important element of care. So bisphosphonates and saline are absolutely the most important 2 elements of management of hypercalcemia of malignancy. The middle 2 less so, and we'll talk about those a little more. But I would argue the first answer should be fluids. So hypercalcemia, this is an image of a calcium ion that was rendered with AI, so thanks to AI, although it looks really quite accurate. The most common cause of hypercalcemia in inpatients is cancer. The other cause among healthy people is hyperparathyroidism, but I found this statistic striking that folks who come into the emergency department with hypercalcemia, over a third of them are going to end up having cancer, even if they did not have a known cancer diagnosis beforehand. So that's pretty striking. Again, relatively common, 1 in 5 cancer patients. And about half, this is in the end stage of their disease, and so they will die within a month. I think there's another proportion in which it's a presenting symptom, and so for those patients it may have a much better outlook once the cancer is diagnosed and treated. The pathophysiology, you know, when I was an early medical student, I kind of assumed this was related to bony metastatic disease. So, okay, the cancer's in the bone and it's freeing up calcium. That sort of intuitively made sense to me. That is a much smaller explanation, so about 20% of the cases. The vast majority are from tumor secretion of what's called PTHRP. So this is parathyroid hormone related peptide. So PTH is a normal hormone in our body, and then cancer releases this PTH related peptide. And what that does is it causes the osteoclasts, which are bone cells that carefully regulate our calcium balance, to sort of rev up. So they start chewing up bone and liberating calcium, and they also increase absorption of calcium through the kidneys. So it sends these signals to the body that we need to get more calcium and make it available. Bony destruction being the second most common, although again it's driven really through those osteoclasts. And then these last 2 are things that show up on tests, at least for medical students, with relative frequency, but don't actually happen in the real world, so I wouldn't dwell on them much. What can cause hypercalcemia? This list, as you can see, covers almost everything, but the ones that I want to highlight are Breast cancer is very commonly associated, as in our case presentation, multiple myeloma, in which it's a diagnostic criteria, and a range of squamous cell carcinomas. So whether that's lung cancer, head and neck cancer, esophageal cancer, etc. The symptoms are kind of vague, and so you do need to have sort of an index of suspicion to consider hypercalcemia in somebody presenting to the emergency department or to your clinic with sort of vague symptoms. So weakness, fatigue, polyuria, meaning drinking a lot, polydipsia, peeing a lot. That's because the calcium ion is essentially a diuretic. It makes people urinate, and so then they become very dehydrated and want to drink more. So that's another important element of hypercalcemia, is thirst and dehydration. GI symptoms can be rather vague: constipation, nausea, sometimes vomiting or pain. There can be psychiatric symptoms, sort of cognitive changes, memory loss, apathy, bone pains. The thing we learned in medical school was stones, bones, groans, and psychiatric overtones. So again, important to have that index of suspicion before you sort of dismiss somebody as just weird. Fortunately, this is not a complex test to obtain. It's part of most metabolic profiles, so you'll get a quick look at what the count is. But when you look at that number, remember that it's just a number. What matters more than the number is the degree or severity of the symptoms rather than the level itself. So there are patients who have pretty quick onset of hypercalcemia from a new cancer that might be 12.5 or 13 and actually have pretty significant symptoms, and that should be managed urgently. On the other hand, you might have somebody who has a long-standing history of cancer that has very, very slowly creeped up, and they might have a calcium level of 15 and are completely asymptomatic. And while we should manage that with a bisphosphonate, that actually does not require quite such intensive therapy. About half of calcium is albumin bound. Many of our patients have low albumin levels, so do remember to correct that. Otherwise, you'll get a falsely low and might assume it's normal when it actually is not. So back to the treatment: fluids. I've put a pretty aggressive rate here. This is how I manage it, is an aggressive upfront rate of fluids. Diuretics are sort of out there in the ether as a treatment option for this disease, and I would say that is not true. Diuretics have a role in the management of hypercalcemia in that if you give them all of this fluid and they develop fluid overload, it's certainly appropriate to manage that with diuretics, but I would not consider them a management for hypercalcemia in and of themselves. Bisphosphonates, all of you are right on that, so that gets to the mechanism of action of that PTHrP-driven hypercalcemia. You stop those osteoclasts from liberating all that calcium, but it does take a day or two to take effect. We typically use Zometa or zoledronic acid or pamidronate. It doesn't really matter which bisphosphonate you use. Almost all of these are renally cleared, and as I mentioned, renal insufficiency, dehydration are not uncommon, so that's important to check and confirm that you're dosing these appropriately. Calcitonin, I would say the residents love to use calcitonin. It is mechanistically really cool because it works just for the first 48 hours as the bisphosphonates are kicking in, but it is not required. It really is only needed for somebody who has severe symptoms where you don't feel like you have 24 to 48 hours to wait for the calcium levels to start to drop. Steroids can be considered in some of those rare cases where this is driven by increased calcitriol. You can consider hemodialysis for patients with really severe burden of calcium, but I just want to remind you, and I'll touch on it later as well, we are talking about some of these are end-of-life type complications, and so it's really important to zoom out for a moment as you're managing these emergencies and take a look at the big picture. If it's a new diagnosis, treatable cancer in a young person, taking an aggressive approach is absolutely appropriate. If it's somebody who is near the end of a long journey with cancer, it's probably worth pausing and asking whether being in an ICU and being on hemodialysis is actually within their goals of care. But it's certainly something that can be considered in severe cases. All right, case 4 is a young man with 2 weeks of rapidly enlarging cervical lymphadenopathy, abdominal distension, and a new fever. He is sick. His vital signs here show that he's got a fever, hypotension, tachycardia, tachypnea. He's got big lymph nodes in his neck and his axillae. His spleen is palpable. You sort of surprise yourself. You go, oh, there's the spleen. And a firm abdominal mass. And you can see his labs here. He's a little bit anemic, has a very high white blood cell count, most of which is atypical lymphocytes, and a low platelet count. He has renal failure with a creatinine of 3.8, a very elevated LDH at 12,000, elevated phosphorus at 9.9, potassium is 6.6, very elevated, and a uric acid also very high at 18.6. And in the real world, you're not going to have these biopsy results, but let's imagine that he had an ongoing workup and had just had a biopsy, that you look in the chart and see that he has a new diagnosis of Burkitt lymphoma. So what should we do next? Combination chemotherapy, steroids, hemodialysis, saline, and resburicase, or radiation therapy alone. And here's that poll everywhere. The fact that everyone's clicking so quickly makes me think you're paying attention, which I love and really appreciate. And we're not going to dwell here because you all have nailed it right on the head. That potassium is 6.6 jumps out, doesn't it? He needs hemodialysis, he needs saline, and he needs a drug called resburicase, which we'll talk about in some more detail. This is tumor lysis syndrome, and this is where I have to show some more appreciation for the AI-generated image. I could not find something, Googling around and looking at academic papers that represented this. But what this is a massive release of intracellular contents from malignant cells. So this is usually from chemo itself, but it can happen from tumors that are just so aggressive and fast-growing that the cells are sort of exploding and dying on their own. And so I do like this image because it shows how all of these metabolic derangements can happen from these cells rupturing and releasing their contents into the body. This is most common in aggressive hematologic malignancies, so high-grade lymphomas, like in our case, Burkitt lymphoma, AML or ALL. You can sometimes see this after the treatment of solid tumors, although those would be highly chemosensitive diseases. So what do we see in tumor lysis syndrome? As we mentioned, hyperkalemia is probably the most life-threatening of the complications folks can develop because it can lead to arrhythmias. Uric acid, elevated uric acid, is, I would say, one of the most convincing diagnostic criteria. Obviously, many things can cause a high potassium, but very few things cause a uric acid level to be this high. So that really clues you into tumor lysis syndrome is what's going on here. And the problem with that high uric acid level is that it is not easily soluble, and so it crystallizes in renal tubules and causes obstructive uropathy and renal failure. Hyperphosphatemia. So again, everything's up. The only exception is hypocalcemia, and that's actually driven by the elevated phosphate levels. So the hypocalcemia can cause problems, including arrhythmias, again, seizures, tetany, which is involuntary muscle contraction. So people can be quite sick with this condition. What are the risk factors that should clue us into tumor lysis syndrome? As I mentioned, high-grade lymphomas, ALL or AML, and you can see here that the thresholds are different because the myeloid blasts are so big and sticky and they can rupture more easily, and so a lower white count in AML is high risk, whereas in ALL you have to get to sort of higher levels for those lymphocytes, lymphoblasts to rupture. But anything with a high tumor proliferation rate, so that's the Ki-67, Ki-67, was discovered in Kiev. That's what the Ki comes from. So any cancer with a high, basically aggressive, fast-growing cancers are at risk for this. And similarly, anything that's sensitive to chemo. So if you're going to give a dose of chemo and you're rapidly going to cause a bunch of cells to die, you can imagine how that can lead to this syndrome. Anything with a large tumor burden, big disease, elevated white blood cell count. And then the last couple things here are sort of patient factors that might predispose them to have problems managing all of these electrolyte abnormalities. So dehydration, pre-existing kidney issues that might impair the patient's ability to get rid of that uric acid. How do we manage it? Well, first let's talk about prevention. We would rather this not happen at all, and we do have a pretty good tool in our toolbox to prevent that, and that is called allopurinol. So if you see one of those conditions I just mentioned, high-grade lymphoma, leukemia, you want to give them allopurinol right off the bat because it's going to decrease the formation of uric acid and thus hopefully prevent this from happening. Almost all of our chemo plans for these conditions include fluids. Again, you're just trying to kind of keep all the metabolites moving through as you start the chemotherapy. And then we'll talk about rasburicase a little bit more in the treatment section, but you can rarely consider it actually as a preventive medication. If it happens, the first treatment, again, is fluids. You want to flush all of those electrolytes out of the system because, again, it's all these contents that shouldn't be there. They need to just work their way out. You want to prevent that obstructive uropathy. Just get all this stuff out. But rasburicase is a phenomenal medication, and I'm going to show how it works in the next slide. It breaks down uric acid, which is not soluble, to allantoin, which is highly soluble in the urine, almost instantly. I mean, most people, a single dose will drop them from a uric acid of 15 or 18 to 5 or 1 or undetectable. It is important to be aware of G6PD deficiency. So this is an enzyme deficiency that has a reasonable prevalence out in the population, a couple of percent. And in that condition, rasburicase can cause what's called methemoglobinemia and lead to red blood cell hemolysis. This is managed differently at different centers. What I would say is if a person is so sick that they need rasburicase, you should give them rasburicase. But you should be aware of the risk of if they have underlying G6PD deficiency, that they could have a second problem, being this methemoglobinemia, and so have an index of suspicion for that. Some places will send a G6PD level before giving the rasburicase, and I think that's reasonable. But if the patient is in acute renal failure and needs the rasburicase, I would go on ahead and give it and just be aware of that as a secondary problem. And of course, we're going to treat the electrolyte abnormalities, shift the potassium, give them calcium gluconate to protect the cardiac membrane, etc. Again, hemodialysis is appropriate in severe cases, so you guys were right on it. In this case, young guy, treatable cancer, we should be full scope aggressive. As mentioned with the previous case, if this is an end-of-life situation, we ought to pause before we hook somebody up to a dialysis machine and make sure that that's what the patient and family want to do. This is a nice diagram that shows this purine catabolic pathway. So purines are in DNA, so anytime you have DNA breakdown, this process kicks off. So purines are converted to hypoxanthine, which is converted to xanthine, and then xanthine oxidase is our endogenous enzyme that converts that to uric acid, which is then broken down to allantoin and excreted. Allopurinol, as you can see, blocks some of those upstream steps, so prevents the formation of uric acid. But if their uric acid is already 18, you've kind of missed the boat on allopurinol. It's not going to solve that problem. I would still use it in those situations because you don't want to add fuel to the fire, but rasburicase is going to rapidly turn all of that uric acid into allantoin and have it easily excreted. I would be remiss to exclude the fact that rasburicase is incredibly expensive, and so this is a really useful tool, but we should be careful in when we use it or just use it when it's appropriate. And again, many patients we can reverse this whole process with aggressive fluid support. Case 5 is another young woman, 28. Maybe I'm accidentally showing my predilection to taking care of young people. A 28-year-old woman who's previously healthy now comes in with 3 weeks of progressive fatigue, shortness of breath, easy bruising. She's afebrile, she has a normal blood pressure, but she's a little tachycardic, a little tachypnic, and importantly is hypoxemic on room air. That does improve with a little bit of oxygen. She's got bruises, she's pale, she has some mild cervical lymph nodes and crackles in her lung bases, but no peripheral edema. Here's her labs with mild anemia, pretty significant anemia, quite elevated white blood cell count with a low absolute neutrophil count and very low platelets as well. Her kidney function is relatively normal, her coags are a little bit deranged, and you get a call from the lab that says she has blasts on her peripheral smear. So what of these is the most appropriate treatment? Imatinib, which is a targeted TKI, targeted treatment, induction chemotherapy, leukapheresis, or rituximab. And here's that poll everywhere. Again, I love the answers coming in quickly. People are paying attention and committing to an answer so they can learn from the results. And I agree with all of you. I would at least consider leukapheresis. I'll sort of walk this back a little bit, but that is the answer that I wanted. That is the correct answer for this question. So again, AI comes through for us. What is leukostasis? It is essentially these big blasts get stuck. Stasis, stuck. Leuko is white blood cells. So these blasts, these big white blood cells, get stuck in the especially in the microvasculature, in the small blood vessels in the body, and they block things. They cause occlusion. They cause pressure buildup, and that can affect basically any organ in the body. And so some of the most common places we see that are places with, again, microvasculature. So the lungs have very small blood vessels to filter and cause oxygen exchange. And what happens is you can have shortness of breath, hypoxemia, infiltrates on an X-ray or on a CT. Neurologically, again, small blood vessels in the brain. You can have altered mental status, blurry vision or double vision, headache, tinnitus, ringing in the ears. Many patients have fever just because this is such an inflammatory reaction. And sometimes you can see spontaneous tumor lysis. You can imagine, again, these cells are getting squished and smushed, and sometimes they start breaking down and rupturing, and that can lead to what's called DIC, which is a severe clotting and bleeding condition. So let's go over some definitions real quick. First of all, hyperleukocytosis is just a number. A white blood cell count of greater than 100,000 counts as hyperleukocytosis, regardless of the cause. Leukostasis, meanwhile, is a clinical syndrome, and it's what we've just talked about. Increased viscosity. These white cells cause plugs in the microvasculature because those blasts are not deformable, and additionally, they're active on the endothelium. So again, going back to the image, you can see it's got all these cells that are sort of coming to figure out what the heck is going on. So that's that inflammatory response. It's activating the endothelium and can cause even more problems. It is most common with acute myelogenous leukemia, although we can also see it in ALL or CML. But I would say we almost never see this in CLL or CML. And in those patients, we can see them come in with white blood cell counts of 300,000, 400,000, and they're completely asymptomatic. And that's because those cells, those lymphocytes in CLL and those myelogenous cells in CML, they look normal. They behave normally. They don't cause those same problems of getting stuck and causing all that viscosity. How do we treat it? Just in case anybody was feeling bold enough to not treat it, this is a fatal condition. So if this happens, I mean, 1 week mortality is 20 to 40%, but I would say it's universally fatal if the underlying cancer is not treated. So how do we treat it? The first thing you're going to do is give hydroxyurea, and that is chemo. It's oral chemo, but it gives some cytoreduction, so it brings that white blood cell count down a little bit. As soon as you're able, you're going to start them on chemotherapy, induction chemotherapy, for whatever the underlying condition is. I'm kind of assuming it's AML in this case. So let's talk about leukapheresis. And again, you guys all got where I was pointing you. This is, I don't want to present this as a simple black and white answer. If they are symptomatic, if they have some of those symptoms, in the case it was shortness of breath and infiltrates and hypoxemia, you should at least consider this. What this is an apheresis procedure, so the transfusion medicine folks have to facilitate this. They need a big line to be able to pull blood off, spin it down, remove all of the white blood cells, and then give the red blood cells, platelets, all the other clotting factors back to the patient. So this is sort of an immediate way to get that white blood cell count from 100,000 down to 10,000. But I want to highlight that this is a very complicated and involved procedure. And so, again, that's why I don't want to paint it as a simple sort of yes-no answer. They need to go to the ICU. They need that line, as I mentioned. They might have low platelets, so their bleeding risk is high. And if you don't start the chemo immediately, as soon as you put the blood back in their system, they're going to start making blasts again. So you could be back in the same place 6 to 12 hours later. And so Leukapheresis is appropriate to consider in patients who are symptomatic from leukostasis, but it needs to always be coupled with induction chemotherapy. Again, you're going to manage the concern for tumor lysis syndrome. And this is the last sort of pearl to note, is their hemoglobin might be 6 or 5, and of course you're going to want to give them a transfusion of red blood cells. But this is a hyperviscosity syndrome. And so if you give them additional red blood cells, you could actually worsen the problem before you improve it. So I would urge, if they need blood, if their hemoglobin's 4 and they're symptomatic, of course you have to give them blood, but you go low, you go slow, use the smallest amount possible. Or you kind of get things lined up to start the chemo or the hydrea or the leukapheresis and add the blood afterwards. All right, I want to make sure we have time for questions, so I'm going to go through our last case here. And then we can have some discussion. So this is geared, I give this talk sometimes for the fellows in our program, so you can put yourself in the shoes of the first-year fellow. You're at home sleeping in bed, you finally got to bed, and your pager goes off at 2:30 in the morning, and you know you have clinic in a few hours. This young patient is calling you. He says, he's got a new diagnosis of diffuse large B-cell lymphoma, and he's got some chills. And he did what he was supposed to do, which is to check his temperature, and it was 100.7. He relays that he was just discharged from the hospital. He got his first cycle of chemo. It went smoothly. He got his white blood cell booster shot, GCSF, just before he left. And tonight he feels fine. He has no new cough, no shortness of breath, no belly pain, no nausea. You're doing a good job. You're asking him all the right questions. Diarrhea, headache, dysuria, nothing. But he lives very far away. He doesn't want flu. He doesn't want COVID. He doesn't want to be in the hospital. He just got out of the hospital. What should we do? So here are your options. Option A is message his nurse navigator and say, can somebody see this guy tomorrow? Option B is let's just both go back to sleep. Option C is you need to drive the 5 hours to UNC so that you can be admitted and managed for this. Option D is I'll send you some antibiotics to your local pharmacy, but if you feel any worse, then you got to come in. And option E is straight to the ER, the closest ER. And here's that poll everywhere. And I really tried to fool you guys. Nobody went with go back to sleep. I'm proud of everyone. You guys are exactly right. The right answer is he needs to be evaluated immediately. This is neutropenic fever. This is an emergency. This is defined by a temperature that the Celsius is 38.4 or 38.0 sustained by over an hour. In Fahrenheit, which is how we still do it in this country, it is 101, any isolated temp of 101, or sustained of 100.4 for over an hour. And neutropenia is a white blood cell count that is less than 500 absolute neutrophils or expected to decrease. So in this patient, even if he had a neutrophil count that was 1,000 or 900, I would still consider this neutropenic fever because he just got this highly myelosuppressive chemotherapy. And the issue here, and this is the way I talk about it with patients, those neutrophils are our first line of defense against any infection. And so when the chemotherapy is going to knock those out, we're missing that first line of defense. And so a simple strep throat or a simple urinary tract infection can suddenly be lethal. And so these patients absolutely need antibiotics, they need cultures, and they need further workup. And I would not have him come to UNC because time to antibiotics is the most critical thing when we talk about infection management, so sooner he can get evaluated is the better. And the risk of neutropenic fever depends on the depth, meaning how low, and duration, how long, of neutropenia, as well as any underlying comorbidities. So this is a useful framework to think about how long people are neutropenic. So in most solid tumors, that's only 5 days or less. Whereas in leukemia lymphoma, that could be 2 weeks, and in bone marrow transplant, that could be months. And the risk of neutropenic fever peaks about a week after chemotherapy. And so you can imagine many of our solid tumor patients, breast cancer, GI cancers, lung cancer, manage to avoid that risk because their neutrophils recover in time. Whereas for our leukemia lymphoma and transplant patients, they're at exceedingly high risk. The other thing to mention here is the pathogens that you need to be worried about. Short duration of neutropenia, you're thinking bacterium and viruses, of course. If you're talking about longer duration of neutropenia, you have to consider some weirder pathogens, particularly fungal etiologies that can develop over prolonged neutropenia. We can sometimes see this without chemo. We can see it at presentation in patients with leukemia and lymphoma. We can see it in patients who have bone marrow involvement of their cancer. That's a particularly challenging situation. And another little pearl is new acute leukemia is functionally neutropenic. I don't care what their neutrophil count is. When they have all those blasts running around, their normal neutrophils do not work. And so a fever in those patients should be similarly managed as a neutropenic fever. And remember to check a differential. They could have a white blood cell count that's 5. That looks normal, but their neutrophils are very low. The approach to the patient is the same as the approach for any patient with an infection. So this is really internal medicine. Thorough physical exam. Look at their skin. Look in their mouths. Look at their line sites. That's an important potential source. Feel in their abdomen. You're evaluating for something called neutropenic enterocolitis or typhlitis. Look at the perianal area. I've had that where patients didn't mention it, but actually had a little abscess, perirectal abscess. One should not do a digital rectal exam. I know people might have wanted to do that, but one should not do the DRE because you don't want to introduce any bacterium that could cause infection. You want to do a broad lab panel, CBC with diff, as I mentioned, complete metabolic profile, urinalysis, and culture, even if the UA is negative, because again, they have no white cells. They might not have a leukesterase. It should still be sent for culture. You should obtain 2 cultures, one off the central line and one peripherally. Of course, send a COVID, and whatever your institutional approaches to infection management should be implemented. If that involves a lactate and an initial fluid bolus, you should take that same approach for these patients because they can get very sick very fast. And there should be some chest imaging. Generally, a chest x-ray is adequate just to see if there's evidence of a pneumonia. And then any further workup should be guided by their symptoms. If they have belly pain, they might need a CT abdomen. If they have a headache and stiff neck, you would have to consider a lumbar puncture. So you want to think about what the symptoms they are having and work it up further. Treatment, again, rapid treatment critical. We generally use cefepime because that's going to give you both good gram-positive and good gram-negative coverage, and you need Pseudomonas coverage for these patients. I add vancomycin when you're worried about a line site infection, catheter-related infection, a severe skin or soft tissue infection where you might be concerned about MRSA, or hemodynamic instability. They're going to the ICU. You do not have time to mess around in case it happens to be a staph infection. I include Zosyn if I'm concerned for an anaerobic infection, something like meropenem if they have a history of resistant pathogens, and then often we add an antifungal if they continue to fever without a clear source. I really appreciate everybody tuning in here, and I think we have a couple of minutes for questions. The point I want to leave everyone with, regardless of your role, regardless of what you do, you should never be afraid to speak up. If you are worried about a patient, we all know that the healthcare system has gaps and there are challenges sometimes to deliver patients the care they need. If you're the person who's closest to the patient and you are worried, you should speak up. And these emergencies are examples of situations that you could be the CNA or the nurse or the medical student. It doesn't matter your role. You could be the first person to notice this, and that recognition is critical. And so speak up, react quickly, use your voice, and take good care of patients.
All right, Dr. Stein, that's an amazing amount of really potent information. And I want to start actually with a question for our audience while we're waiting for questions to come in. If you've ever heard from something, whether it's from Dr. Stein or from any one of our numerous presenters. We've been doing this almost a lecture a week for over 10 years now. Wow. We'd love to hear your stories from our audience. So if you have something, and obviously with preservation of patient confidentiality, but something you can tell us about that you learned in a lecture that has made a difference and you're taking care of patients, please let us know. We'd love to hear those stories. We'll go ahead and open it up. Let me jump in with one of mine. I know you mentioned with the hypercalcemia bisphosphonates, and we had a lecture a little while back where we actually talked about osteonecrosis and concerns there. Are there if somebody's closer to end of life and you believe that to be the case, I'm guessing that's less of a factor. But with a younger patient, would that factor into prescribing bisphosphonates?
Yeah, it's a great question, and certainly osteonecrosis of the jaw is a serious complication and a challenging complication. I would say these are not necessarily long-term medications, so you're going to give them a dose of bisphosphonate when they're in the hospital. That doesn't, but then you're going to treat the underlying cancer, and so it may be that they only get 1 or 2 doses of bisphosphonate, and then you can stop once the cancer is managed. And so I wouldn't be too worried about that. If it's going to be long-term, then of course you need to consider that and discuss that risk with the patient.
Okay. Thank you so much for that. And let's go ahead and get to some of these questions because we do have some coming in. First one, let you take that.
Yeah, so the allopurinol, as I mentioned, if their uric acid is already very high, it's not going to resolve the problem of an elevated uric acid. However, if there's ongoing tumor lysis, if you remember that purine catabolic pathway, if there's still cells, DNA being broken down and working its way through, you would maybe like to dam things up above so that things aren't continuing to get worse. And so I would use allopurinol in addition to the other steps because you can sort of prevent fuel from being thrown on the fire, if that makes sense. Good question.
All right. Here's another question relating, and I'm sure a few of you have thought about this, but what if a patient has to wait 5 hours in their local ER?
This is an excellent question.
Yeah.
And this is sort of where the real world meets, the textbook. I have evolved the way that I talk to patients about this. I don't want the patient driving 5 hours to a medical center because I think that's too long. But I've had patients say, I'm not going to such and such hospital because I don't trust the care that I'm going to get. And so what I have shifted to say is go to the closest ER that you trust. If the patient and family don't trust a place, I'm not here to sort of litigate that, but patients should trust their judgment. And I think that's your point here. But get to somewhere where they trust, get into care as quickly as they can.
Okay, thank you. Nice comment here. This has been incredible. Thank you for a fantastic presentation.
Thank you.
Do you use the MASCC score for febrile neutropenia?
Yes, we do. And actually, I'm really interested in this. So this is a severity scoring system. So you can look at lab criteria as well as some of the patient's cancer sort of details about their cancer and their treatment to determine how high risk they are for complications. I am sort of trying to pilot patients with a low MASC score, so a low risk of complications from their neutropenic fever, can actually be treated in the outpatient setting. That doesn't mean they can skip the emergency department. They still need to come in, be seen, and evaluated. But if that initial evaluation kind of looks okay, I have done this with some patients at low risk, and they can be sent out with oral levofloxacin as long as they have an exceedingly close management plan. So I love the use of scoring systems to tailor patient care. Great question.
And we are on the hour, so we'll make this our last question.
Okay. Are there scenarios in which starting rituximab ASAP would be appropriate? Yes. I mean, I would say lymphomas would be the situation. So rituximab is a CD20 monoclonal antibody. So if you had a disease, as many lymphomas are, that are driven by CD20 B cells, then rituximab as part of that, so R-CHOP is one of those examples, rituximab as a part of that emergent treatment would be very appropriate in those cases.
All right. And before I do these other thank yous, I want to say a huge thank you to you. For those in our audience who don't know, Dr. Stein's lecture is our top attended lecture of all time. In the combined enduring materials and live, we awarded over 700 certificates for this, various types, CNE and CME and pharmacy, et cetera. So it's amazing, and we're very thankful
Wow.
that information has gotten out
Yeah.
to so many people across the state, so many professionals.
Well, thank you, Tim, and I agree, as you're saying at the end, it's great to me that people are paying attention and listening and learning about these topics because, as I say, they can make a big difference.
Yeah. We want to thank the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, the team, Benny Obore, John Powell, Oliver Marth, Andrew Dodgen, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all of their hard work on each and every one of these lectures.